A 41-year-old female presents with progressive shortness of breath for 6 months and back discomfort. I am showing you chest computed tomography images in bone and lung windows. Describe the findings.
Let's see. Yes. The sagittal thoracic CT in bone windows demonstrates multiple well-defined sclerotic foci within consecutive vertebral bodies and subcortical regions of the sternum. Several of these sclerotic lesions contain small central lucencies, but there is no vertebral height loss or associated paraspinal soft tissue mass. The axial CT images in lung windows reveal numerous randomly distributed thin-walled cysts bilaterally, alongside fine, bilateral peribronchovascular nodules. There is no significant pleural effusion. The combination of skeletal sclerotic lesions and coexisting pulmonary cysts and nodules is highly diagnostic of multisystem Langerhans cell histiocytosis.
What is the typical sequence of pulmonary findings in Langerhans cell histiocytosis, and how does it differ from other cystic lung diseases?
Pulmonary Langerhans cell histiocytosis typically starts as small centrilobular nodules, which represent peribronchial inflammatory infiltrates. Over time, these nodules cavitate to form thick-walled cysts, which gradually mature into thin-walled, irregularly shaped cysts that can coalesce. This process classically spares the costophrenic angles and exhibits an upper to mid-lung zone predominance, closely linked to a smoking history. This distribution and nodular phase help differentiate it from lymphangioliomyomatosis, which causes uniform round cysts distributed evenly throughout the entire lung without nodules, and lymphoid interstitial pneumonia, which features scattered cysts associated with ground glass opacities and is linked to Sjogren's syndrome.
Explain the significance of the sclerotic bone lesions in this patient and how they relate to the pediatric presentation of Langerhans cell histiocytosis.
In adults, bone involvement in Langerhans cell histiocytosis often presents as sclerotic foci or lytic lesions with peripheral sclerotic margins, which represents a healing or chronic phase of the disease. In contrast, pediatric osseous involvement is typically acute, presenting as aggressively osteolytic lesions without sclerotic borders, or as uniform vertebral body collapse producing a vertebra plana. Sclerosis in the adult skeleton signifies a benign, resolving course for the bone lesions, meaning they do not require aggressive follow-up unlike the active pulmonary lesions.
Discuss the systemic syndromes associated with Langerhans cell histiocytosis and their classic clinical triads.
Langerhans cell histiocytosis can present as a localized disease or as part of a systemic syndrome. Chronic multifocal Langerhans cell histiocytosis, historically known as Hand-Schuller-Christian disease, is characterized by the classic triad of diabetes insipidus secondary to pituitary stalk infiltration, exophthalmos from sphenoid wing involvement, and lytic skull lesions. Lederer-Ciué disease is the acute disseminated form, typically presenting in infants under 2 years of age with hepatosplenomegaly, lymphadenopathy, bone marrow dysfunction, and diffuse skin lesions, carrying a much more aggressive clinical course.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this CT scan with any prior chest imaging to evaluate the progression of the pulmonary cysts and nodules. I would suggest obtaining a dedicated high-resolution chest CT, HRCT, to evaluate the cyst morphology and screen for complications such as pneumothorax or secondary aspergilloma formation within cavities. I would recommend a brain and pituitary MRI to evaluate for infundibular thickening or diabetes insipidus, especially if there are any systemic symptoms. Finally, I would document the findings, recommend genetic testing for BRAF mutations, which are common in histiocytic disorders, and refer the patient to a multidisciplinary team involving pulmonology, oncology, and rheumatology.